like to call upon Dr. Thomas Cherian. He is the president, KSOS. He needs no introduction in our setting. And I'd like to thank him for coming on board and encouraging me in this endeavor. Dr. Thomas.
Good morning, and thank you, Sheena. I was faced with two challenges when Sheena asked me to do this. First, of course, we really enjoyed doing this Smart India study, being part of the study, picking up data, collecting and collating data and all that. But once these reports came out, it all sounded Greek and Latin. And I've been reading these reports over and over again for the last couple of weeks. Still, I have a lot of knowledge lacunae in this. That is the first challenge. And the second is Dr. Rajalakshmi is a live wire in this study. And to speak after Dr. Rajalakshmi is even more challenging. Anyway, I'll try to do my best. We again discuss about two articles. One is sight-threatening DR and the need for risk-based stratified screening. Diabetes and its complications lead to common causes of morbidity and mortality globally. And the low-income and middle-income countries are the most affected by this diabetic epidemic, and there's a large unmet need to screen for pre-diabetes and diabetes in our country, where primary healthcare is underdeveloped and the laboratory tests are costly. I'm not speaking about Kerala as a state, but of India as a whole here. The objective of the Smart India study was to evaluate the risk-based stratified screening models for diabetes and its complications, and to develop and apply statistical and economic models to personalize screening approaches, optimizing resource use in India. The research questions were: how can risk-based stratification improve the efficiency and outcomes of diabetic screening in India? What is the economic impact of different screening strategies for diabetes and its complications? And how can personalized screening reduce the burden on healthcare systems while ensuring optimal health outcomes for the individuals? As far as WHO is concerned, these have all been discussed. We have symptomatic patients above HbA1c is 6.5 is considered as diabetic. And normal HbA1c is less than 6, and anything more than that is either pre-diabetic or diabetic. And despite its variability, random blood glucose is the most common blood test done in a mass screening program even now. But if we have the more convenient point-of-care HbA1c kits which are now available, it shows a good correlation with laboratory-based HbA1c estimation. Approximately 30% of people with diabetes present with macrovascular complications such as cardiovascular, cerebrovascular, and chronic kidney disease. There is no systematic screening due to economic constraints, paucity of public health programs, and inadequately trained manpower. We identify sight-threatening diabetic retinopathy with images either manually or with artificial intelligence, and retinopathy screening is done with handheld cameras, which is an efficient and cost-effective screening option. These were the centers which was shown earlier. The study design and methodology was a multi-center approach, a risk-based stratified screening. We had a statistical modeling using advanced statistical models, and to make it cost-effective, we have had an economic modeling also, universal versus targeted screening. The three objectives, we were trying to look at ideal tests that could identify people at risk of diabetes and pre-diabetes, and found that a point-of-care HbA1c levels evaluated were comparable to or even statistically better off than testing a random blood glucose. Now, the circulating biomarkers for assessing sight-threatening diabetic retinopathy, we tried to identify circulating biomarkers. The previous discovery and verification studies have reported a selection of circulating biomarkers with good diagnostic power to identify those with STDR. And this was aimed at evaluating previously verified blood biomarkers using ELISA for their potential usefulness as indicators. The main goal was to evaluate the diagnostic performance of these biomarkers, and the research questions were: can circulating biomarkers reliably identify individuals at risk for STDR? HbA1c, glomerular filtration rate were all measured in hospital laboratories, and the samples were anonymized before transfer to the laboratories. The selected biomarkers, these were the selected biomarkers which were studied, and cystatin C and leucine-rich alpha-2 glycoprotein 1 were the ones which ultimately mattered. Sensitivity analysis was carried out to compare the area under the curve of closely related biomarkers, serum creatinine and cystatin C. And in addition, cystatin C levels were compared between STDR group and no DR group with normal kidney function, as elevated cystatin C levels may be attributable to diabetic kidney disease rather than sight-threatening diabetic retinopathy. This was the analysis of the expression patterns in the UK part of the study. Cystatin C to the addition of cystatin C to the base model yielded an area under the curve of 0.779, and leucine-related alpha-glycoprotein to the base model yielded an area under the curve of 0.763. When it was extrapolated or when it was studied in the Indian arm of the study, again these two, especially cystatin C, was the significant biomarker which we identified in the India arm of the study. In the UK population with estimated prevalence of STDR relative to no DR is of 6%, that means if 1,000 people with no diabetic retinopathy or sight-threatening diabetic retinopathy undergo retinal screening, 60 out of 1,000 would be identified as having STDR. While if you take those cystatin C positive people, then 274 out of 1,000 patients would be classified as STDR. In the India part, when cystatin C was used, 115 out of 1,000 were picked up in the India part against 52 without the screening with the biomarker. When cystatin C levels were added to age, again an area under the curve of 0.779 compared to 0.735 without cystatin C was obtained in the UK. The validity of this strategy was similar in both UK and India. Therefore, the results suggest that the biomarker was useful in both the countries. Now, the strength of the study, both the India and UK models achieved close to acceptable discrimination. Second, the models relied mostly on routinely collected data except for cystatin C. However, a point-of-care cystatin C biosensor may be accessible as a web-based application for self-monitoring by the patients. And data for cystatin C used in our final model did reflect as seen in our literature. Now, we had a few limitations. That's pooling of samples from UK and India were not entirely possible due to logistical reasons. The validity of cystatin C point-of-care kit is needed before use in a healthcare or community screening setting. And serum cystatin C has also been shown to be an early marker of diabetic kidney disease. That means those with diabetic kidney disease also have a higher prevalence of sight-threatening diabetic retinopathy. To conclude, this is a promising diagnostic tool to have circulating biomarkers for picking up sight-threatening diabetic retinopathy. We need future research with additional multicenter studies, and we need clinical integration. Once validated, biomarker-based testing could provide a valuable supplement to the existing models. Thank you.
Thank you, Dr. Thomas. It's very interesting to see how even we all know that retinal imaging is the gold standard for DR and to detect DR, to screen for STDR. And it's interesting that a simple blood test could also help us point us in that direction. And even assessing risk factors alone without a fundus examination also could help us point towards STDR. So I think the final take-home points Dr. Rajalakshmi will elucidate to